Okay, it's a foreign language. The object of you getting to the place where you can go to is to learn the language. If you look at it like that, it's really quite simple. We just have to learn how to speak the language. I'm going to throw words at you today that you've never heard before. So, I don't want you to get too flustered by that. All the words that I'm going to say today are in that textbook, which I picked this year because I think it's a great book for learning radiology, because it's called Learning Radiology. And secondly, because there's a great web access to everything in the book. I understand it might be a little pricey, and I apologize for that. If you can get it, it's a book that you're going to refer to for the rest of your careers, unless you go into psychiatric, become a psychiatric PA, which might not look at any extras. But for just about everything else, it really is a good book. So last year, the folks were just freaked out about exams, and I understand. I mean, medical school was 2 exams a week for 2.5 years, so I understand what you're going through as well. You're not going to see anything on the exam that I haven't said. You're not going to see any image on the exam that either isn't on these slides or in the book. Okay, so I'm not going to throw any crap at you. It's going to all be there in front of you. I really do. The book is very readable. The slides you should have access to, right? You'll have access to all these slides. So you're never going to see or hear anything that isn't that you haven't seen in the lecture or that's in the book.
Where are you slides?
That probably haven't been uploaded because, but remind me at the break to upload them. I can put them on this PC easy enough. And as long as they get on this PC, I think you guys can get at them, right? Should be able to. I don't know. So I'm sorry you don't have my slides now. Do you want them now?
I think it's lecture 3 on the time lectures.
No, I've modified this in the last 2 days. So. Those were from last year.
Yeah. Is the book that you're referring to available online, or we need?
You have to buy the book to get the web access. Okay. 3 or 4 of you could buy 1 copy to share the access. Yes, sir.
The summer book list listed the 2nd edition, I believe, everywhere else.
That's the one.
Is the second?
Everyone most people bought the 2nd edition. Is that okay?
It's all the same.
Okay.
And radiology doesn't change.
Do you have access? Do you have online access?
Yes, I know you want the slides. I just don't know how to get them to right now, but
To the book online?
In a couple of hours.
Yeah, I think so.
And then I'll make sure
sure.
to put them on here. But I know that they know how to get them to you. Okay, because I wish I'd done that.
If I can share it, yeah. I don't know if I can
All
share
right,
it,
so
but if I can, yeah.
I kind of changed the order around for the
But I mean, I could
four
get
lectures.
access to it.
What I'm going to do today is just talk about. I'm not going to talk about
using
physics. I'm not going to talk about how an X-ray is made. I'm not
If you
going to
wouldn't
talk about any of that stuff. We're going to just jump right into a chest X-ray, and we're going to the first part of this. The first couple of hours, you can dig out the chest X-ray and some imaging things that you're going to have to know about. The second part will be the cardiovascular, very important. So, next time we'll start with breast and mammography. We're going to talk a little bit about radiation and stuff like that. Brain and spine imaging, neuroradiology. And then the last 2 lectures will be pediatrics and musculoskeletal and GI and GU. So we're going to cover everything. It's just, unfortunately, it's going to go fast. I'm from New Jersey. I speak fast. If I'm too fast, just slow down and don't hesitate to interrupt. I don't really mind interruptions. Just understand I really would like to get here to get that because I'm not sure you what it is, right? So let's
Where'd you get the slides? Are these these are the different slides, huh? For the new one here.
So the first part of it today is going to be about the chest X-ray, okay, chest radiology. We're going to review all the anatomy, the pulmonary anatomy, that's the lungs, the cardiovascular anatomy, that's the heart and the vessels, okay. The osseous anatomy, all the bony structure you should be expected to see on a chest X-ray. We're going to talk about some of the most common chest X-ray findings that I would expect you to be able to identify, or somebody would expect you to be able to identify if they just threw a chest X-ray at us and said, radiology is learned by looking at images. Radiology is 4 years long, and looking at images and learning how to do it. Okay? So obviously, you guys are going to be able to have a chance to look at all kinds of imaging during your training and during your career, but probably none more useful to you than chest X-ray, okay? Because that's what everybody gets all the time. So we're going to go through that basic pathophysiology in the lung, the alveolar portion of the lung where all the gas exchange happens, and then the interstitial portion of the lung which supports the structure of the lung itself. Then we're going to talk about the pleural anatomy, the lining of the lung, okay, because there's lots of pathology that goes on there. So when do you order a chest X-ray? The real question is, when do you not order a chest X-ray? Because everybody gets a chest X-ray for just about everything, right? You get it for a pre-employment physical. You get it for, you go to the ER with a cough, you're getting a chest X-ray. You get it before you get minor surgery. So everybody gets a chest X-ray because everybody has a chest. And inside the chest are obviously structures that are crucial, but also are telling surgeons and other physicians, is this guy going to be able to undergo this procedure, right? Or can we tell why this guy has a cough? So everybody gets a chest X-ray, and it's just about the most ubiquitous image that you're ever going to see. We do chest X-rays in 2 conventional views, and I'll talk about this a little bit later. The PA view, or the postero-anterior view, and the lateral view, right? So we'll show you the images, we'll look at them. They'll look familiar to you, but then you'll start thinking to yourself, what exactly is all that stuff in there? We're going to go over all of that. If a patient has any suspected vascular disease, something wrong with the aorta, a section, or a pulmonary embolus, all of these things can be diagnosed not necessarily with chest CTs, although everybody who gets a chest CT is going to get a chest X-ray. We'll do a little bit about CT down the road, but I'm not going to get too bogged down in chest CT. For second year, you'll have the pleasure of getting and we'll be talking about a lot more in-depth radiology then, a lot more cross-sectional imaging, a little more advanced stuff than we're going to do in this session. This time, next year in the spring. Any suspected mass, potential cancer, lung tumor, for anybody. Tumors love to travel, and one of the places they love to travel is the lung and the chest. If you've got a melanoma, you're almost certainly going to get a chest X-ray to make sure you don't have a melanoma spreading to your lung. Okay, not a good thing. So how do we start looking at a film? Let's not even think about the film first. Let's think about the patient. Remember always, compare to the patient. Let's make sure that when we look at an image, no matter what image it is, ever, that you're talking to the right patient. Okay? Because even though we've got computers and all kinds of digital stuff these days, mistakes get made, things get transposed. You can get patient X and it's patient Y. So be very, very cautious about making double sure that when you're looking at an image of anything, you've got the right patient. Make sure you understand that, make sure you understand the history. Has the patient had any previous images? Previous images for radiologists are like gold. If you show me an image of anything, you can CAT scan for the chest. The first thing I'm going to say is, does the patient have a previous CAT scan? It's critical for me to be able to compare, to know what happened, what was there in the past, what's there today. So when your friendly radiologist says to you, previous images, please don't reflexively say, how the hell should I know? Okay. Reflexively say, yes, there are. Or yes, we know the patient had a CAT scan in Idaho in 2009. Okay. Even if you don't have it, it's good to know. So that's kind of some of the history taking that you guys are going to wind up doing, especially when you know you're dealing with potentially a disease that is very imaging sensitive. Okay, so a lung cancer, for example. have a patient you know has a lung cancer, and you're seeing them for the first time, you're going to want to find out when the cancer was diagnosed, what kind of imaging studies they've had, how many they've had, where are they, okay? And if they're obviously in our system, locally, we find them. If they're not, we very well may need to get them. We can help get them, you can help get them, but previous images are critical. We're going to talk a little bit about trying to identify what makes a good image, what makes a good chest X-ray. How do I know that the image is adequate for diagnosis? We're going to review the normal structures. When you're looking at an image, when you're looking at a film, you want to review the normal structures, make sure you identify all the normal structures, because sometimes it can be difficult to tell the abnormal from the normal. Make sure you understand, as you go over time, you'll start to understand this, that a pediatric chest doesn't look like a 90-year-old chest by any stretch of the imagination, and there are differences. They may be perfectly healthy, but there are tremendous differences that we have to be able to recognize and understand. Okay, this 90-year-old has a calcified aorta. Well, the aorta's been around for 90 years. It's probably okay to be calcified. But if a 5-year-old has a calcified aorta, that's a problem. Right? People talk a lot about how do you approach an image? How do you look at it? How do you do it differently every time? Do you do it the same every time? Radiologists are trained to look at an image the same way every time. That doesn't mean that we're all trained to look at it all the same way. But everybody has to find their own search pattern that works for them to make sure that they don't miss anything. So all of radiology really is search patterns that are burned into my brain for 30 years of doing this. And every radiologist has a different search pattern, but it's a search pattern that works for them. I'm not here to suggest that all of you are going to find some kind of magic search pattern that is going to make you find everything in every imaging study you ever see. Imaging is going to be a part of what you do for a living. It's not going to be everything that you do for a living as it is for me. However, when you approach an image, you should start thinking about, all right, I got to make sure I see everything. So how do I standardize my look at everything so I don't miss something? It's kind of like a checklist. You know, Atul Gawande wrote a book about checklists and how you should use checklists. Airline pilots use them so that they don't make mistakes. Same thing is true in radiology. We use a mental checklist that we go through every structure, every time the same way. You're going to do something like that as you get more and more experience. You're not going to do it tomorrow. You're not going to do it next month. You may not even do it next year. But as you get more experience, and especially if you get, if you go to work for an oncologist or if you go to work for an orthopedic surgeon, you're going to start looking at a lot of bone films. You're going to start looking at a lot of MRs. You may not necessarily know all the physics, but you're going to start looking at these things very constantly. You're going to look at them the same way. You're going to try to look at them the same way so that you make sure you don't miss something. Of course, always trying to give a reasonable potential diagnosis. You can often be absolutely precise about what we see and say that is precise definition of a radiologist. Sometimes your radiologist will not be as precise. The fudge, sometimes will give you most likely options of what the diagnosis is. Although some of us are. But it means that we're trying to, we have to weigh the evidence that's in front of us, all the history and all the clinical information that we are given, which is often difficult. But we have to come up with the most likely diagnosis, next 2 or 3 diagnoses that are possible, and after that, I quit. I don't know that many diagnoses. Okay, I'm just not going to go for number 8. I can't count that one. So we're going to look at this picture. We're going to look at this picture. I'm going to embarrass somebody by just asking somebody to volunteer and tell me what it is that they see. Go right ahead.
So I see the diaphragm, the heart.
Okay, you're seeing this thing here, right? And that's the diaphragm.
Yeah.
You're seeing this thing here.
And that's the heart, which is yeah.
Okay. And then you're seeing these things here, which are the
Roots.
The black stuff.
Lungs.
Okay, the black stuff is the lungs. The white curvy things are the ribs. Good. There's a dark thing down here. Good. And then, of course, we've got the stuff in the corners of the films, right? The shoulders and this thing is the. Okay. So, I can just tell you about where I look at the chest X-ray. I always start from the middle, start from the center. I always make sure, the beautiful thing about the human body is for many structures, there's tremendous symmetry, right? We'll, next lecture, we'll look at some brain stuff. Okay? Brain CTs and brain MRI. You can think of brain slicing right down the middle, and the right half looks exactly like the left. Okay? That's almost true in the chest, but obviously it's not, right? I mean, there's something over here that isn't over here. There's something over here that isn't over here. But when there's something like near symmetry in a study, I always start in the middle. So I want to clear everything in the middle of the chest. I want to clear this bag of something. It was called the heart. But remember, there's more than just the heart, right, in here. We call this whole thing the mediastinum, okay? Because in the mediastinum is the heart, is the esophagus, a bunch of nerves, okay? The thoracic duct, a whole bunch of other stuff. So there's stuff in there that's more than heart. But let's just think about how the image looks and why this is dark and why this is kind of grayish and why these bones are white. Anyone have any idea why that is? Yes, sir. The density of the tissue. I would say that is almost exactly right. The only thing I would qualify is that our bodies are virtually 90+% water, right? So the density, that is the D equals sort of the density of everything except the bone is essentially water density, even the lung. Okay. The thing that I would say is that we need to think about is it's the way the X-rays interact with the density. Okay. So we've got X-rays coming at. So the way this film is taken is I'm standing against the film like this. The film is right in front of me. The X-ray tube is behind me. So the X-rays are coming through they're being generated at the tube, they're coming through me, and they're hitting the film, okay, or the detector. We don't use film anymore, we call them detectors. Used to use film. So in some portions of the chest, the X-rays clearly are acting differently. Something different is happening to the X-rays that are encountering the bone, and the X-rays that are encountering the lung, and the X-rays that are encountering the soft tissues. Okay? So what is happening? The radio density of the lung, because it's got a lot of air in it, the tissue is still water density. But because there's a lot of air in the lung, the X-rays just fly right through. Okay? So for every 100 X-ray photons that hit a section of lung, 99 of them just go right through, hit the detector, and when they hit the detector, they cause something to look dark. Okay? Unlike, say, for example, the X-rays that encounter this vertebral body. That vertebral body is bone. It's denser. It's more radio dense. And so when the X-rays hit that bone, instead of 99 out of 100 getting to the detector, maybe only 90 out of 100 get to the detector. And 10 are scattered or absorbed or lost. Okay? So where the detectors see a lot of X-rays, we get white. Where the detectors see relatively little X-ray, relatively speaking, we get white. And so that's why the chest X-ray looks the way it does. So for the most part, you're absolutely right. It's the density of the tissue, but it's really the density of the tissue as it is interacting with the X-ray photons. For the moment, we just want to I don't want to say anything really more about X-ray physics. You will get a little bit more about that next year from me, but right now it's really not that great. So one of the things we should also look at with this film is its positioning and its adequacy. So let's start talking a little bit about. Sorry, I should go back here. So we've got densities here. We've been talking about densities. We've got soft tissue. We've got bone. We've got air, lungish density, right? And in radiography, when I say radiography, I mean any image that is taken that looks like, how shall I describe it? That's done with X-ray photons only in a single plane. Okay, so CAT scans use X-ray photons. but we refer to radiography as like a joint film, or a chest film, or an abdomen film, okay? So in radiography, you're going to encounter these several densities, okay? Air, which is what we see in the lungs. They absorb the least X-ray and look blackest on conventional radiographs. Then the next density up is fat. So fat and muscle are essentially water, but fat happens to be less radiodense than muscle. So X-rays go through fat easier than they go through fluid or soft tissue or muscle. So there's air, which is the blackest, fat, which tends to be gray, fluid or soft tissue, which tends to be a little less gray, a little more white. And then there's calcium, like bone, which is going to be even more white. And then there's metal, which essentially is all white, because most metals do not allow any X-ray photons to go through them for the energies of X-ray photons that we're talking about. So if you have a hip prosthesis, your patient has a hip prosthesis, and we do an X-ray of the hip, we're going to see the bone around the prosthesis. We're going to see the prosthesis as this white thing, but we're not going to see anything. Okay. So let's talk about now we've got these densities in our mind. We've got this image of a normal chest X-ray in our mind. Let's talk about already described that the most that's actually 2 meters. I described to you before where that film was taken with me standing. The X-ray beam was behind me, my back, my front. That's called a PA, anterior chest X-ray, and it's always described. The direction to the patient. If I had been laying in a bed, we do these portable films in the ICU, where the detector is put on the patient, the X-ray machine is put on the patient, this is above the patient, and they the X-ray PA and AD. Well, you would say, well, they're the same thing, aren't they? I mean, their imaging is the same. Physics, magnification. So we always refer to the direction of the X-ray beam. AP view tends to have structures for a couple of reasons. Anytime you look at a chest X-ray, something should PA or AP. We want to do all of our chest films whenever possible because chests are done in ER, they're done in the ICU. Our patients are obviously killed, good breath, there's magnification to go with, so we always prefer to do whenever possible. Of course, we turn the patient and do light views, right, where instead of straight on or straight on from the back, turn a little bit this way. Is there any utility to that kind of information? There is, but it's usually for us trying to solve a particular problem. One of the things you're going to have to get to understand in radiology is you take one view of something, one view, like that chest X-ray we showed you. You take one view of the chest. If there's an abnormality sitting right here, you don't know where that is. It could be very interior. Chest. It could be on the anterior chest wall. It could be very posterior in the lung, posterior chest wall. View doesn't tell you anything about where something is. You have to do what we call orthogonal views. And the lateral view of the chest is orthogonal. Because it's 90 lateral view of the chest. If I look at both of those views, I can tell you where something is. If I can see it on both views, I can tell you if it's anterior or posterior. Oblique views also help me tell where something is if I know which way the patient is turned. Okay? Not something that you're going to get by just thinking about it. It's going to take a little bit of time. Yes, sir.
The lateral, what's the standard? Do the ribs come from the left?
And we're going to get to that. The standard lateral view is the left side of the patient is against the center. So the picture beam would come right and go into the left. That's the standard. We don't call it a right-left lateral. So there are these specialty views for the chest that we like to use when necessary. Typically, a radiologist is going to suggest, hey, I need like these because, for example, a nipple can look like a mass. It could be a female or a male, it doesn't matter. A nipple could look like a mass. And if you just show me one view, I see this mass in the lower chest, and I can't tell you where it is. I can't tell you if it's on the chest wall. I can't tell you if it's behind the patient. I can't tell you if it's on the detector. I can't tell you if it's in the band. I can't tell you any of it. But if you turn the patient, and it turns the anterior structure to turn, then I can tell you that that's a nipple. Right? I don't have to do anything more. If it doesn't do that, then I can tell you it's probably a mass and further investigation is required. We do these views called lateral decubitus views where the patient is lying on their side. That's very useful to be able to see if any fluid in the chest is actually flowing. So if there's fluid in the pleural spaces, when we lay the patient down on their side, I want to be able to know, does that fluid flow freely? If it flows freely, I can stick a needle in it and pull it out. Or is that fluid loculated? Is it stuck down in a collection where there might be more than just a simple drainage? Okay? An apical lordotic view of the chest means that I want to see what's way up in the apices because the frontal view of the chest can actually block that stuff. Sometimes there's a mass sitting up here and you can't see it. But if you do an apical lordotic view, and I'll show you an example, those clavicles get thrown off the top of the chest, and I can see the apices, the lung apices, much better. Okay, we've done this. So this is the positioning for the postero-anterior chest, right? Patient, this is the detector. The X-ray beam's over here, cutting this way. This is what a postero-anterior chest looks like. This is the lateral view of the chest. The patient's left side is against the detector. The X-ray beam is over here, and we're shooting that way. Okay, and here's the lateral view of the chest. So this is the anterior part of the chest, right? So notice how the heart is in the front of the chest. Well, we will know that kind of intuitively. But if you look at that chest X-ray, the frontal one that I showed you, you just look at this one, you have no idea if that's in the front of the chest or in the back of the chest. So you must see everything in two views. This is not just for chest X-ray. This is why we do 4 views of the wrist. This is why we do 3 views of the shoulder. This is why we do more than one view of just about every anatomic structure. Because you can never be sure where something is, where a fracture fragment lies with respect to another fragment, unless you have it in 2 views. And then you have to build this spatial model in your brain of where things live. So radiology in general is for, it particularly appeals to people who like to, see things in 3 dimensions when they only are forced to look at something on a 2-dimensional piece of film or a monitor. Okay, so we're talking now about the way the chest X-ray is performed. We talked about positioning. Let's talk about technique. Okay, there are 5. Usually if you see something in yellow text on my slides, that's something that you're going to want to be aware of. Okay, that might possibly come back. And you might see it. Okay, so there are 5 essential technique things that we want to be able to see. This is something that X-ray technologists and always refer to an X-ray tech as a technologist. Never call them a technician. If you call an X-ray tech a technician, you're going to get a nasty look. They're technologists. Okay. We want to assess the degree of X-ray penetration. Is the film too dark or too light? If it's too dark, it's over-penetrating. Too many X-ray photons flying at that patient. So many of them hit the film with the detector, that the detector is essentially black. Or too few. Too few X-ray photons hit the patient. And now I can barely see anything, it all looks washed out. These are all settings that the technologist will choose based on the patient's size and ability to cooperate, etc. These are something that, I mean, you'll never have to worry about it. You have to rely on a good technologist to do. The degree of inspiration on a chest film. You ever had a chest X-ray, you know what they say just before they shoot it. Take a deep breath and hold it, heat, and then they expose it, right? We want those lungs to be as inflated as they can be under normal physiologic conditions. Patients in the ICU, patients in the unit, patients on a ventilator, you can't take a deep breath, right? Those are always under ventilated films, okay? And they're tricky to diagnose, they're tricky to read. My job to read them. You know, we have strategies on how we can do that, but ideally you want to see a chest X-ray at full inspiration. You don't want to see any rotation on that lateral or on that that frontal view. If this is the frontal view, I don't want to be turned a little bit like this. I don't want to be turned kind of looking goofy like that. I want to be perfectly straight on all the time. The magnification is an issue when it comes to the AP projected films, and I'll show you why that is in a little bit. So the heart and the mediastinal structures can actually look enlarged on a perfectly normal AP film. So it's always useful to know how the film was taken. Usually our technologists tell us that they had to take it AP, or and usually I can tell just by looking at it. And then angulation. Did the beam hit me perfectly perpendicular, or did the tech have the tube angulated, and was it somehow angulated differently? So these are the things that we want to make sure in our minds, that you're going to want to make sure when you look at a chest X-ray. Are all these things right? Is this film adequate to interpret? So on penetration, we kind of want to see the spine through the mediastinal soft tissues. Okay, you want to be able to see, and I don't know if you can see it here, but you can see the vertebral bodies through here, so that's good. You want to be able to see the diaphragm against the lung. You want to be able to see it all the way to the spine if you can, and you want to be able to see these pulmonary vessels out at least about a half to 2/3 of the way out. That tells you that the film is adequately penetrated. Now, the beautiful thing about modern computers and digital imaging now is that the tech can see a little bit and penetrate a little bit, and I can compensate for picture archive and communication and the system, my CAT system. Every radiologist today reads films on computers. So we can adjust that. We can adjust the image to compensate for slightly over-penetrated or slightly under-penetrated films. Used to be able to put a picture on the film, you were supposed to do anything with it. So here's an example of an overexposed film. Way too many photons, too much X-ray energy hitting the patient, and then subsequently hitting the detector. Here's one of underexposure. Too few hitting the detector. This is light and kind of washed out. And could I miss something down here? Sure. Something going on here? Yes.
Is there anything you can gain from underexposed or overexposed film?
Probably not. Probably not. I would say that sometimes you might want to deliberately overexpose an image if you've got metal. But the problem is that if you've got metal in an image, these a lot of X-rays are done where the machine actually there's a feedback loop. So there's a detector, there's a sensor in the detector that says, yes, for what you told me this patient weighs and for their size, I'm expecting this many X-ray photons. And if you try to override that, it'll shut down. It won't create as many X-ray photons as you want to if you've got it on auto detect. The answer to your question is almost never. Okay, there's almost never a good reason to overexpose or underexpose somebody. I can't really think of one off there.
We just take it back to review some films, like looking for glass in the soft tissue.
Yep. Now that would be, I was about to say that foreign bodies might be something that you might want to do. These
It's rare.
Yeah, sure. These days, especially for superficial foreign bodies, when they say they're looking for a foreign body, I say get an ultrasound. I'll find an ultrasound a lot faster than I would especially because wood and glass are actually very similar to soft tissue in the way they transmit X-rays. You'd think that glass, you would find glass easily. Glass is almost impossible to see. Wood, especially if so you stuck a fresh twig, right? It wasn't dead, it was fresh. Had a lot of water in it. You can almost never see wood. The only thing you really see in that is the air inside the wood. That's what you see. You don't really see the wood itself. Okay, so we talked about depth of inspiration. You want to see the diaphragm at about the 10th posterior rib, and we'll go over that. If the patient is hyperinflated, the diaphragm will often be below the 10th rib, close to the 10th posterior rib. It's very difficult, if you're a normal person, to overinflate your lungs. Okay, if you don't have COPD or emphysema, it's very difficult to do it on purpose. If you have COPD or emphysema, it's almost impossible not to be overinflated, and your lungs are going to look like, your lungs are going to be overinflated, and I'll show you some examples. It's this one that's the hypoinflated lungs that are the chronic complications in the unit. Patients who are on a ventilator, they don't often really time the exposure to when the patient is given a breath. So they're going to shoot it pretty much just when they're going to shoot it. And if the patients aren't really able to take a deep breath, if you've got a chest wall injury and you're spinning, or if you've got pneumonia and you've got thoracic chest pain, to take a deep breath really hurts, right? So it's hard sometimes to get films done at full inspiration. So here is a good inspiration film. Ribs are funky things, okay? You're going to have to learn that ribs are a curved three-dimensional structure that is kind of flat to the back and then comes down and becomes oblique, and they're very difficult to see. But always know that these ribs that are mostly horizontal, those are the posterior ribs. Those are the ones that are coming off the spine. The anterior ribs can be very difficult to see, and then right about here's an anterior rib that's curving here, and then right about here it becomes cartilaginous, where it joins with the sternum. The cartilage is just, you're not able to see much cartilage at all on X-ray unless it's calcified. So you're not seeing any cartilage, so you don't really see where the anterior rib joins the sternum. That's completely cartilaginous. But these are posterior ribs, the ones that are horizontal. So this is the 10th posterior rib, trust me, I counted them myself. And so the diaphragm is just there, just a little below. So that's a well inspiration film. On this one, though, the patient really doesn't have any disease per se, but it has not taken a great breath. So the diaphragm is right here. It's at about the 7th posterior rib. But notice how the heart looks a little bigger, how all the vascular markings in the lung bases are crowded, right? So how do I know that there's not an infiltrate hiding back there? How do I know there's not a pneumonia back there? How do I know there's not pulmonary vascular congestion? Well, I can tell that the patient has made a poor inspiration, so I can pretty much hedge my bets, right? That the patient probably, but I will say, in my report will say, that the examination is exposed at suboptimal pulmonary volume, okay? It just means that I'm telling you flat out, the study is suboptimal. Doesn't mean that it's bad, it's the best that the tech could do.
Would you consider the hypoinflation picture to be exposed improperly because it's light?
Yeah, it might be a little light, but it's part of it is your eyes seeing this, and this one looks good, right? But this one, because of it could be the same patient with the exact same exposure, but because the patient didn't take a deep breath, the lung volume, there's less air in here, and so for the same technique that the tech chose, fewer photons got to the patient. Okay.
Of the patients that you said are always hyperinflated, would you still ask them to take a deep breath?
Well, yeah, the techs like do it because the techs do it almost out of habit. So you ask them to take a deep breath, and the guy's like, I've already got so much air in my lungs, I can't. Because they can't. They really can't get it out. I should have asked, are there any X-ray techs in the room? I knew you were. Okay, so if I say something stupid, will you please correct me? Okay, because it has happened. I was once in here last year and I said something really dumb. I said something really dumb, and there was an X-ray tech. Yeah? Sorry? So I said, is there an X-ray tech way in the back? Okay, so you're going to hold me to it, right?
All right.
All right, so anything done yet?
No, you should.
Okay, good. So here's an overinflated chest, okay? Maybe this guy really didn't have COPD. Maybe he was actually very healthy, but he really got it down, okay? But it's really hard to get it. It's really hard to do it on purpose. So 12 posterior rib. I don't think I've ever said this is overinflated because the patient just took a wicked breath. So yeah, you want to be about. So let's talk about rotation. Remember, I said that the chest is almost symmetrical, but there are some things in the chest, especially at certain levels, that are really symmetrical, like the trachea being in the midline. Okay, you really do want to see your trachea in the midline. The other thing you want to see is that the ends of the clavicle, the medial ends of the clavicle, should be equidistant from the spinous processes, or from the middle of the spine. So if your patient doesn't have scoliosis, and so their spine doesn't go like this, right? And if your patient doesn't have a mass that's pushing their trachea to one side or the other, and if your patient hasn't had the medial end of their clavicle because of osteomyelitis or something, you want to see that trachea in the midline. You want to see those medial ends of the clavicles essentially equidistant from the midline, which is the spinous processes of the upper thoracic spine. Okay, and you can't really see them here, but if you look closely at this image, there's these little white circles with a loose center. Those are the spinous processes that you're seeing. They're in the back of the spine, but they're something that you can see if you look for them. So that's what you want to see. Now, I talked about oblique views, and I want to just spend a minute about how to tell when something is on the anterior or posterior part of the chest, or in any X-ray you look at. So here's a patient. The detector is back here. There's an orange dot on their right shoulder and an orange dot on their left shoulder, and the corresponding image that you would see would be this orange dot and this orange dot. If the patient turned with their left side anterior, this is called an LAO projection, left anterior oblique. Okay, you don't have to write this stuff down because, I just want you to understand how we name things. Okay, so in the LAO view, notice how the dot, it didn't change its anatomic position with respect to the patient, but it actually changed its position on the image. Okay, and sometimes I find myself doing this very stupid-looking thing. I really sometimes have to think about where something is. I'll put two fingers in front of my eyes like this. This is the anterior part of the patient. This is the posterior part. I'll say, okay, this lesion is anterior. When I turn the patient LAO, the lesion should turn to my left. Okay. If I turn the patient the other way, the lesion should turn to my right. Okay. And or if it's posterior, the lesion, and I turn the patient this way, the lesion should turn to my left. And if I turn it the other way, the lesion should turn to my right. I still find myself doing this 30 years of being trained. Okay, just to keep my mind straight. So similarly on this one, the orange dot has not changed its anatomic position, but notice how it moves toward the middle when on the detector on the image when the patient is turned. So you can use obliquity of the patient to help you understand where something is. And you'll often find your radiologist may say, I think we should do bilateral obliques so I can tell where this thing is. It's cheaper than doing a CAT scan. It's cheaper than doing an MRI. Just to redo these X-rays in very shallow obliquity to tell you where something is. So on this patient, on this study, the patient is turned to the left, okay? Because the left clavicle, I always get bogged down with this because, I really don't want to spend a whole lot of time on it, but I want you to try to understand if you can. And if you notice how the right clavicle goes to the left, and the left clavicle goes to the left. So the patient is turned with the right side is turned up and the left side is turned back. And the opposite is true on this one. The end of the right clavicle has gone to the right, the end of the left clavicle has gone to the right, the trachea is to the right of the midline. And so the patient is turned with its left side up and right side back. We don't need to get too crazy about it. I just want you to understand that that's how you can tell which obliquity. And if you all go home, have a beer, and do this, you may need a psychiatrist, okay? But that's the way we do it. So we've talked about PA and AP. We'll talk a little bit about upright and supine. We talked about the lordotic view to assess the apices. I'll show you this. The cubitus views, I'm going to show you these right now. One thing I'm not going to show you is the inspiration sometimes it's useful to have a patient completely blow all the air out of their lungs and then take an X-ray. Okay, it's called an expiration view of the chest. If you have, and it's often useful in people who you suspect have a obstruction of the airway to one of the lungs. So picture a little kid who's aspirated a peanut, okay, and he's coughing. You can do a chest X-ray at full inspiration, and you might see two well-aerated lungs. But if that peanut is blocking the egress of air out of that lung, and you have the patient force expiration and take a picture, the normal lung will have become small, right? All the air will have gone out. And the lung that's being obstructed will still be full, right? Because the peanut is blocking the airway. So we sometimes will do a forced expiration view to look for foreign body aspirations, and sometimes you can also see air around the lung better in patients who force expiration. So this is the PA versus the AP. Lower text, PA and AP. So here's your patient. Here's your X-ray tube, 72 inches behind the patient. On an AP view, the patient is supine. The detector is down here in the table. Here's the tube, 40 inches away from the patient. These are conventions. This is the way it's always going to be. Okay. Now, that PA view is the one I said we would really like to try to do whenever we can. But sometimes we have to do that AP supine view. But look at the difference in the size of the heart. Okay. On the AP view, the heart is going to generally look larger than on the PA view. Why is that? If the detector is right up against my chest and the beam of X-ray is coming from behind me, the beam is just consider it's like a fan beam, okay, it's going out like that. Well, my heart is very close to the detector, so the detector is going to detect the size of my heart almost exactly at its real size, okay, because there's only a very short distance between the detector and my heart. However, if you flip it so that the beam actually comes from the front of me and goes to the back, now there's more distance between my heart and the detector. So that fan beam that hit my heart when it was that wide now gets to the detector it's that wide, and now the heart looks bigger. Usually I draw some stuff on the thing, but I cannot suck at drawing, so I'm not computer. So an AP view is going to show magnification of anterior structures in the chest. That's why we prefer not to use them as a routine, but for all practicality, we're looking at AP chests all the time for patients in the unit who are critically ill. This is a way that lateral decubitus view of the chest is. So I've got a patient who I think has fluid around their lung. And again, I want to be able to know, is that fluid free-flowing or is it blockulated? How much fluid is there? So if I think the patient has fluid on their left side, around their left lung, I'm going to lay that patient down on their left side. I'm going to have the X-ray tube behind them. I'm going to have the detector, the piece of film right here, okay, held up by the tape. I'm going to shoot that X-ray through the chest. I'm going to be left with an image that looks like this. The patient's head is over here now, and the foot is over here. So here's the heart, here's the left lung, here's the right lung, and notice that I've got this level of whiteness. It's actually the fluid that's layering along the long part of the chest. So I can tell you that there's a pretty large pleural effusion on that side, and that it's free flowing. It goes all the way up to the apex of the chest. So that's important information for whoever might want to drain that fluid or open that chest. You're going to want to know how much fluid is there. Can the fluid be taken off? That kind of stuff. Yes.
Is that view usually done from posterior to anterior?
It is usually, yes. It's not. It's almost. In fact, it almost always is. Yes. Okay. I told you earlier about that apical lordotic, where you want to be able to see the apices, because sometimes a small lesion can hide up in here, but be hidden by the clavicles. So if you notice how the clavicles here are above the first rib, actually the first rib is right there. The clavicles are just about at the level of the first rib. But I can see just about everything up here really nicely, which on a regular chest X-ray I sometimes cannot see. Okay. Let's take 5 minutes. I've been on the phone all morning.